Good morning to sir, respected Sunil sir, all dignitaries and my respected teachers, seniors and colleagues. Today we are presenting CCR in collaboration with the Department of Oncosurgery, Oncopathology and Prosthodontics on 48-year-old female with a chronic oral ulcer. Before this, I just want to give a brief introduction of our departments and some of the work in the last 1 year. So this is in our Oncoplastic unit. We, along with me, the Dr. Shikha Goyal, who is recently promoted to the associate professor, working with us, me in our unit. In the last 1 year, in 2023, we did about 432 number of the microvascular reconstruction of head and neck, lower limb trauma, and along with the regional flap, about 57, in which 466 are the head and neck reconstruction cases, 6 cases of breast reconstruction, and 8 cases of the reimplantation. Out of these, we have total 21 number of the cases of free flap failure, and with success rate of 95.13, which is equivalent to the most of the institute in the world, which vary between 94 to 96. And we did about 5 number of the publication in the last 1 year in 2023. So this is one of the our original research article published with the usually in the free flap monitoring we do blood check every 2 hourly by pinprick and clinical examination. But in this article we monitor free flap with the help of blood glucose level of the flap in the rest of the body, so that we check survival of the flap at the blood sugar level. So this is one of the innovative articles we published from our department. In the resources we have one surgical microscope. Last year I presented same CCR on foot reimplantation. That time we were using ENT microscope, and that time we discussed about it. I would like to thanks to our management and sir to provide this high resolution microscope, which make our work very easier. Micro instruments, and we also have rotational posting of the MCH plastic care residents for every month in our department. So we started the fellowship program. So we getting a number of candidates from not only the national but also the international level. One of the Muhammad Adel from the Egypt visitors in the November December. Dr. Sania recently completed 1 month fellowship from Kerala, and Dr. Prasanna is with us. This month we will one fellow from the Greece and one from the Hyderabad also join our department. So these are some of the accolades we get. In the last year in August on Independence Day, we got the certificate of excellence by the Honorable Sunil sir for the field in microsurgery. This is one of the prestigious oration which I delivered in the plastic surgery department of KGMU. This is the Dr. S.K. Bhatnagar oration. This is one of the national, international level. There was a competition among all over the plastics in the world. We got in which we got the gold award with the cash prize of the $1,000. So I also invited in various national microsurgery of WSRM, European microsurgery, and Asia Pacific as an invited speaker. So I now invite Dr. Swapnil to present the case of CCRs.
Good morning, respected faculty, teachers, my colleague in the Mahatma Gandhi family. Myself, Dr. Swapnil from the Oncosurgery department, presenting the case 48-year female with the chronic oral ulcer. 48-year pleasant lady, tobacco chewer, homemaker, come to Mahatma Gandhi with the ulcer left side inner cheek for the 8-month duration, swelling left side of the jaw for the 3 months. Patient was apparently asymptomatic before 8 months. Then she developed a small ulcer at the left inner side of the cheek, which was initially small in size and gradually increased in size up to the present size. It is associated with the pain, which is insidious in onset, intermittent, burning in nature, and increase the intensity of the pain while chewing the food on the left side and the spicy food, and the relieving the pain by eating a semi-solid and the liquid diet and took some oral medicine. The pain is present over a 7 month of duration. As the size of the ulcer increases, it involves the left lower gingivobuccal sulcus as well as the alveolar surface, which will leads to the loosening of the first premolar and the molar teeth. It is also associated with the foul smelling from the oral cavity for the past 4 months. Along with that, as the size of the ulcer increases, it also leads to the left side of the jaw swelling since last 2 months. And patient also complains of the bleeding on touching the ulcer since last 1 month. There is no history of similar complaint in the past, history of dental trauma, history suggestive of complaints related to the ear, nose and throat, history of neck swelling, history of high-risk sexual behavior, no history of fever, jaundice, chronic cough, weight loss, and recent onset bony pain. Patient is hypertensive since 2 years, and it's well controlled on the tablet amlodipine 5 mg OD. No history of any drug allergy, no history of diabetes, tuberculosis, chronic obstructive pulmonary disease, and the coronary artery disease. No history of any previous surgical history. Patient is a tobacco chewer, eating 4 to 5 packets per day since last 20 years, and the stopped tobacco chewing last 3 months back. Patient is gravida 2, para 2, having 2 living children, postmenopausal since 2 years. There is no history of alcohol and smoking. Patient is on vegetarian diet with normal appetite and unaltered bowel and the bladder habits. No significant family history. So my history summary is 48-year hypertensive lady, tobacco chewer with painful gradually progressive ulcer on the left inner side of cheek from 8 months of duration, associated with the loosening of teeth and the swelling at the left side of the jaw. So I would like to ask my colleagues what could be the probable differential diagnosis on the basis of history. Yes, yes. So on the basis of history, as the patient doesn't have any autoimmune disease like symptoms, so autoimmune disease is not there. Infective is plus or minus, it could be TB, but patient does not have any high-risk sexual behavior, no any other sign symptoms, so infective could not be there. It could be malignant. So now I would like to do general examination as well as the systemic examination. On general examination, I have examined the patient in the proper light and proper exposure. Patient is conscious, alert and oriented to time, place and person. Temperature is normal. Right radial pulse is 80 per minute with normal rhythm, tension, force and volume. Blood pressure is 126 by 78 mmHg, right brachial artery in the supine position. Respiratory rate is 18 cycles per minute, thoraco-abdominal. Body mass index of the patient is 28.76 kg per meter square and the ECOG score is 0. No pallor, icterus, clubbing, cyanosis, pedal edema and the generalized lymphadenopathy seen. On oral examination, there is a left lower face asymmetry is there. Upper jaw dentulous with all teeth present. Lower jaw partially dentulous in relation to loosening of the premolar and the first molar teeth. Tobacco staining of the teeth is there, halitosis present, and the inter-incisor teeth distance is 2 cm. On inspection, there is single 5 into 3 cm ulceroproliferative lesion which extend from the left lower GBS from canine teeth to third molar teeth, which also involve the alveolar mucosa with everted margin and the irregular surface. Distance of the growth from the angle of mouth is 1.5 cm and from RNT it is 1 cm. Rest of the oral cavity is normal. This is the growth. There is not a separate growth, but as the size of the ulcer increases, from the inspection it looks like this is a jaw swelling which is patient presented to us. So on examination, on inspection from the from front of the patient, this look like a single 3 into 2 cm oval swelling present at the left side of the body of the mandible with normal overlying skin. There is no any fullness noted in the neck. On palpation, I confirm my inspected finding, which are 5 into 3 into 2 cm ulceroproliferative growth, which present from the which present at the left lower GBS, involves the alveolar surface with firm in consistency and bleed on touch. Rest of the oral cavity is normal. On palpation, there is a loss of sensation at the chin area is present. There is a palpable, single, hard, mobile lymph node which is 1 into 1 into 1 centimeter in size present at the level 1B. No any other palpable lymphadenopathy present in the neck. Rest of the systemic examination within normal physiological limit. So my case summary based on the history and the examination is there. 48-year hypertensive lady, tobacco chewer, presented with the ulcer at the left side inner cheek and adjacent swelling over 8-month duration. Ulcer at the left lower GBS with the size of 5 into 3 into 2 centimeter, which is involving the alveolar surface, which extend from the canine teeth to third molar teeth, involving the mandibular swelling, chin anesthesia, and the left 1B significant node. So I would like to ask my fellow colleagues, what could be at present, what could be the most provisional diagnosis of this case? So basis on the history and the examination, what are the findings that favors the malignancy? First is the duration, second one is the extension, third one is the hard in consistency as well as the bleed on touch, hard neck node as well as the loosening of the teeth. All these factors that are leads to the provisional diagnosis of the malignancy. So here we rule out the infective cause as well as the autoimmune cause. So the final diagnosis of this case is carcinoma, left lower gingivobuccal sulcus, clinical staging T4 N1 M0. To proceed further, we requested for the punch biopsy, and the punch biopsy is suggestive of the moderately differentiated squamous cell carcinoma of grade 2. On workup of this case, we requested for the blood investigation, CBC, LFT, RFT, PT-INR, viral markers, and the blood group which are within normal limit. And for the radiological examination, we requested for the CCT neck, which is suggestive of the heterogeneous mass of 5 into 3 into 2 centimeter, which involves the left buccal mucosa, left lower GBS as well as the alveolus, and there is an erosion of the body of the mandible. Along with that, for the metastatic workup, we also requested for the CCT chest and the USG abdomen, which is within normal limit. So according to the 8th AJCC classification, patient comes under the T4, which involves the tumor invades the adjacent structures as well as the more than one lymph node. Yes, sir.
Are you showing any clinical picture?
Sir, it is covered in the later part, sir. Later part of the reconstruction, it covers all the pictures, sir. Multiple lymph node involvement, that is N2, and there is no metastasis, that is M0. So the final diagnosis of this case is 48-year hypertensive lady, tobacco chewer, with the squamous cell carcinoma of grade 2 of left lower GBS with clinical T4 N2 M0. So the case is discussed in the multidisciplinary team, and with the discussion of this team, the tumor is, we are able to excise the tumor with the oncological safety with the proper 1 centimeter margin. So plan for the surgery. According to the NCCN guidelines, this is also we also follows this NCCN guidelines. According to that, resection of the primary and the ipsilateral or the bilateral neck dissection. So after the routine pre-op workup, fitness from the anesthesia and the cardiology department as well as the counsel and the written consent, we proceed for the surgery. There is a plan for the composite resection, neck dissection, and the microvascular free flap reconstruction. As during the surgical procedure, we found out that during the mandibulectomy, there is a widening of the mandibular canal and there is a malignant looking suspicious tissue over there. So we requested for the intra-frozen section, and the intra-frozen section report come out to be positive for the malignancy. So we proceed for the left lower GBS composite resection with type 3 mandibulectomy and the bilateral neck dissection.
Good morning, dignitaries. I am Dr. Shikha Goyal from the Department of Oncopathology. So I will be discussing the frozen section which we received during the operative procedure. So during the operation, if a surgeon is suspecting any bony involvement, so he will send us the bone marrow specimen. So in the first diagram, as we can see that this is an anterior bony margin which we received, And here we can see the bony trabeculae in the lower part of the image. The bone is replaced by the fibrotic tissue, and these are the nest of the squamous cells. So on frozen section, a diagnosis of anterior bone marrow margin positive for malignancy was given. So on the basis of this finding, the surgery was revised and we received the subtotal mandibulectomy specimen. So this is the gross image of the subtotal mandibulectomy specimen, and then we took the margins using a bone cutter, and bone is decalcified, and this is the final HPE image of the bone at the level section, H&E stain section, showing the bony trabeculae and the malignant squamous cell. So I just want to say that frozen section diagnosis, it should be remembered that it is just a provisional diagnosis, and final diagnosis is given on the formalin fixed HPE section. Thank you. Now I would like to call Dr. Neelanjana to further continue the case.
Good morning. I am Dr. Neelanjana Chakraborty from the Department of Plastic and Reconstructive Surgery. So let us discuss over here what were the intraoperative challenges that we as a plastic surgeon had faced during this surgery. The first being that the pre-operative plan for us was a segmental mandibulectomy, and this was the resection that we were expecting. However, the frozen section was positive for bony margins and bone marrow, and hence the surgical plan was decided and changed during the intraoperative period, and a near total mandibulectomy was done, and this was the resection which was done. This was the intraoperative defect which was handed over to us for reconstruction. As we can see, the entire lower jaw mandible was removed, only preserving the bilateral condyles. So here comes our task for reconstruction of such a complex defect. Before I move forward, I wanted to ask the audience, can you identify this character? Can anyone?
Andy Gum.
Yes, very right. So this is Andy Gum. This was a comic character which was famous around the 1920s to 1960s, which was based on a character, real life patient who underwent total mandibulectomy for his treatment. Now when we see this photograph, this facial picture, what are the striking features that comes to our mind which makes this face noticeable? Yes. So as we can see, there is an absence of the lower jaw. There is absence of the lower 1/3 of the facial height, along with the lower lip deformity which can be appreciated here. So when such a patient comes to us, this is defined as an Andy Gum deformity. The patient will come to us with complaints like excessive drooling, difficulty in chewing, airway will be compromised, and aesthetic issues are there with the patient. So in our patient also, in order to prevent such a Andy Gum deformity, it was very important that we went ahead with a meticulous planning for reconstruction. The surgical options that were available to us for mandibular reconstruction includes either we go for prostheses and implants like reconstruction plates, titanium prostheses or Dacron meshes, or we go ahead with autologous bony flaps. The autologous bony flaps available to us are fibula osteocutaneous flap, the iliac osteocutaneous flap, the scapula and the radial osteocutaneous flap. These are the photographs of the prostheses that are available to us. But after planning for this particular patient, looking at the defect size and the functional implications which are associated with the patient, the best option for us was to go for an osteocutaneous flap. And the osteocutaneous flap of choice for us was the fibula osteocutaneous flap. So why did we go ahead with a free fibula osteocutaneous flap? Firstly, the bone length that can be harvested in a fibula ranges from 25 to 30 centimeters, which is enough for a reconstruction of mandible. Secondly, just because this bone is highly vascularized, it gives us opportunities for multiple osteotomies to give a better contour to the reconstructed mandible. Thirdly, the donor side mobility is less in case of a fibula as compared to the other options available. There is an availability of skin and muscle also which can be harvested along with the bone, which gives us a better bulk for the reconstructed mandible. Then The pedicle length which we have is enough and adequate for the anastomosis in the neck region. The bone is easy to reshape and give a better contour to the neomandible which is to be reconstructed. And just because it is a cortical bone, the bone firmness is enough which gives the strength to the mandible which is being reconstructed. So once we have decided, a free fibula osteocutaneous flap was to be harvested. Now this is based on the nutrient artery which is derived from the peroneal artery, and the minor pedicle comes from the periosteal and the muscular branches which are also derived from the peroneal artery. Preoperative planning is a very effective tool for any kind of surgery. In our case, what we do is we mark the perforated vessels in the patient beforehand using a handheld Doppler. For this, what we do is we mark the lateral malleoli and the head of the fibula. The fibula is marked and the posterior border of the fibula is identified. The posterior border of the fibula is the one which represents the posterior intermuscular septum, which has the highest number of this perforator vessels, which is found in the middle third of the fibula. So these perforator vessels are marked, which we mark using a handheld Doppler. After the preoperative marking and the planning, we go ahead with the mandibular reconstruction. This is an intraoperative procedure and it is done in a single stage immediately after the resection has been done. We mark we estimate mark the defect size, and eventually we mark the flap to be harvested. So the first stage of mandibular reconstruction is to harvest a free fibula osteocutaneous flap. This is the position of the lower limb which we kept. The knee is flexed at 90 degrees and the hip is internally rotated. The markings are done for the fibula osteocutaneous flap. These are the marked perforator vessels which can be seen over here, which were marked earlier, and this is the inside we can see the marked perforator vessels on which the fibula flap is harvested. After harvesting the flap, this is the bone along with the skin and the muscle. We perform osteotomies or wedge osteotomies for the mandibular contour. So to give the contour, we do wedge osteotomies, and these, as you can see, these are the 4 osteotomies which were done. These are the parts which were used for the reconstruction of the neomandible. So this was used for the reconstruction of the right and left ramus, this for the body, and this was for the central part. Once the reconstruction was done, osteotomy done, this was the neomandible which was reconstructed. As we can see, the 4 osteotomies done, and these were stabilized using titanium plates and screws. Once we have harvested and created the neomandible, the next stage is of flap insetting. So once it is created, we can see the flap is inserted in the earlier mandibular region and fixed to the condyles. This flap has been inserted. This is the pedicle which we can see, which is used for the microvascular anastomosis with the neck vessels. For the microvascular anastomosis, the microvascular anastomosis is done under microscope magnification with an 8-0 suture. The anastomosis is done using an end-to-end anastomosis of the peroneal artery to the facial artery, and the venous anastomosis is done as an end-to side anastomosis of the vena comitans along with accompanying the peroneal artery to the internal jugular vein. Once the microvascular anastomosis is also done, we give the muscle coverage to the flap. This is given using the flexor hallucis muscle, which was also harvested along with the free fibula. One of the advantages of the free fibula flap, that muscle, skin, bone, all availability is present over there. This, as we can see, this was an immediate post-operative photograph of the patient. Since the skin was preserved and not involved, skin coverage was given and wound was closed. As we can see over here, even in the immediate post-operative period also, the facial symmetry is maintained and the jaw contour was restored. These were the pre-op and the post-operative photographs of the patient, post-operative follow-up at day 7 and day 21. As again over here in the pictures it is visible, and we can appreciate that the symmetry is maintained along with the neomandible. The jaw has been restored. The profile pictures of the patient. This was a small video which was recorded in the post-operative day 7. As we can see, the jaw movements have been restored already. It has started to come. This was the post-operative OPG that we had taken. As we can see over here, the neomandible made fixed to the condyles with the 4 osteotomies and the screws and plates used to stabilize it. The post-operative course for our patient, on day 0, the procedure was uneventful. Patient was shifted to SICU. Day 1, the patient was extubated. Patient was vitally stable and RT feeding was started immediately. On day 5, the drains were removed, and on day 6, we had discharged the patient. Now, looking forward, what are the future prospects which are available for the patient now? First is, as per the NCCN guidelines, the patient will be subjected to adjuvant radiation therapy after 4 to 6 weeks of the surgery. The second is dental rehabilitation, which is to be done after completion of the radiation therapy. So for the dental rehabilitation prospects, I would like to call Dr. Riddhi to explain further.
Excuse me, Dr. Neelanjana.
Yes, sir.
Excellent presentation. I really enjoyed your descriptions.
Thank you, sir.
One question that I had was, you told us about the pedicle anastomosis, the artery
Yes,
in the
sir.
vein. How
Yes, sir.
about the nerves? Muscle, when you are excising the muscle from the fibular region, you are probably denervating the muscle.
Yes, sir.
But the muscle is contracting there, so how did you innervate the muscle?
Sir, in free fibula also, we can involve for the sensory, we can involve the superficial peroneal nerve. It can be involved and can be taken with the flap also. But over here, we did not. It was not taken. Only the arterial and venous anastomosis was done, sir. It was basically the muscles and the jaw which was fixed is helping in the movement, sir.
So the muscles that were taken along with them, they are simply for a cosmetic
Yes, sir.
effect rather than functionally for movement of the jaw.
So it gives actually basically the muscles which were taken, they give the bulk to the bulk to the free fibula which was harvested. Yes, shape. First it aesthetic. Secondly, sir, even
the muscles which are taken there along the artery only. Rest of the area is being removed. So the muscle cuff.
The muscles cover the bone. That is very important because patient has to undergo radiation. If the bone is exposed just below the skin, there are high chances that the patient can go osteoarthritis. So if the muscle is there, it gives bulk, cover and protection.
yes, thank you, sir.
My question to oncology, if it is an R0 resection, then why adjuvant radiation?
This would obviously not be an R0 resection. We didn't show the final histopathology, but the
Yes.
node was positive, and the node was, this is N2 disease and T4 disease. So anything more than that will require no, sorry, it is an R0 resection from that point of view. Yeah. But it will require radiation because of the staging.
Greetings for the morning to all the dignitaries, staff, faculty, seniors and my fellow colleagues. I, Dr. Riddhi Dhadda from the Department of Prosthodontics, Crown and Bridge and Maxillofacial Prosthetics will give an overview about the future prospects of dental rehabilitation of the lower jaw. As we all know, even after an extensive, excellent reconstructive surgery, prosthetic rehabilitation remains incomplete for the patient because of compromised mastication and speech because of absence of teeth. Here comes the role of a prosthodontist. The patients with head and neck cancer surgeries require prosthetic rehabilitation to enhance the quality of life. So it is very important for a pre-operative planning with the prosthetic team and the dental restorative viewpoint in any given situation. There are various goals which we achieve and strive to achieve for further dental rehabilitation. These are mastication, speech, dental aesthetics and improved quality of life. As we all know, prosthetic rehabilitation starts after a year of completion of radiotherapy and a clearance from the oncosurgery department. We need to preserve the soft tissue graft as for the enhancement of the tissue survival and the treatment success. Prosthetic rehabilitation consists of two, the removable prosthesis and the fixed prosthesis. Removable prosthesis, as the name suggests, the patient can remove the prosthesis himself. It consists of two, conventional dentures and the implant supported dentures. Conventional dentures are acrylic based prosthesis with artificial teeth over it. It takes its retention, support and stability from the anatomical landmarks of the mandible, soft tissue and the physiological functioning of the tongue and saliva. Implant supported dentures are not only conventional dentures but enhance their retention from the implants placed in the mandibular symphysis region. Fixed prosthesis consists of the hybrid prosthesis, which is the new advancement in the prosthetic rehabilitation. These are titanium frameworks with acrylic and artificial teeth over it, which are retained through multiple implants within the mandible. The procedure as follows. In the surgical phase, which is the phase 1, the implants are placed within the mandible, covered with healing screws. In the second phase, which starts at the 4 to 5 months of osseointegration phase of the implant with the bone, the transmucosal abutments are placed and either the conventional impressions or the digital scans are taken. The third phase is the prosthetic phase, where the final screwing of the prosthesis with the implant takes place. There are various challenges during a prosthetic rehabilitation. One of them is the patient motivation. The patient needs to be motivated well through various counseling sessions as the patient undergoes through various surgical interventions and radio and chemotherapies. Second is the debulking of the soft tissues. The bulky soft tissues makes the denture unstable and reduces the prosthetic space. Third is the reduced bone height. It compromises with the size of the implant and increases the prosthetic space, which causes prosthetic failure. The fourth is the trismus, which is restricted mouth opening. In various patients, it is difficult for us to start with the recording impressions till the final prosthetic insertion. The primary stability of implants. Due to various radiation and chemotherapies, the bone quality reduces, the anchorage and the immobilization of the implants are compromised. The last but not the least, the cost factor, which also decides the treatment plan. Now I would like to thank the Department of Oncopathology and Oncoplastic Surgery for giving us the opportunity to call upon the dental rehabilitation processes.
So why did we choose this case for CCR? So these were the challenges that we faced. That the frozen section came positive, which eventually led to the change of the plan, which led to the near total mandibular reconstruction. The integrity of the perforative vessels were a challenge for us because the patient was a tobacco chewer. Next, not only an anatomical but functional implications were also associated with this reconstruction. This is a journal which was published in the Maxillofacial Plastic and Reconstructive Surgery in December 2023, which stated that from 1980 till date, around 11 cases of total mandibulectomy reconstruction using free fibula flap has been reported. My take-home message for everyone would be that autologous bone flap is a preferred method for mandibular reconstruction nowadays, as we replace the same tissue, bone to bone, soft tissue to top soft tissue. With advancements in the microvascular surgery, oral cavity cancers which were earlier considered unresectable are amenable to resection now, as we have many more reconstructive opportunities and options. Effective mandibular reconstruction using free fibula flap offers not only an aesthetic but a functional outcome, providing the patients with enhanced quality of life and restored oral function. A comprehensive surgical planning, meticulous technique and a multidisciplinary collaboration are paramount for successful outcomes, which we can see in our case also. I would like to thank lastly the patient and the relatives, the hospital management for giving us this opportunity, the CCA review committee who helped us all throughout this week, the collaborating departments of surgical oncology, anesthesia, radiology, oncopathology, prosthodontics, the OT, ICU and ward staff members which made this possible for us. Thank you.